Our next speaker is Professor Brendon Mccormick. Professor Brendon Mccormick is head of the Division of Nursing and head of the Graduate School at Queen Margaret University in Edinburgh, honorary nurse consultant in gerontology, and is a much-travelled has a much-travelled portfolio of professorships in many universities around the world. His writing and his research work focuses on person-centered practice, gerontology, nursing, and practice development, and he has a particular focus on the use of arts and creativity in healthcare research and development. So I'd like you to welcome Professor Brendon Mccormick to talk about person-centered care. Thank you.
Good afternoon, or I could probably now say evening, actually. So congratulations on your resilience, I think I should say first, in staying put for this whole conference, because it's certainly a packed day and a long day. This seems to be a conference about bringing the expats back home as well, which is very nice, and it's always very nice to be back here, which I do quite a lot. I was asked to speak about person-centered cultures and in the context of care and compassion, and that's what I want to do in the 20 minutes or so, the clock is already ticking, that I have this afternoon. And really I'm going to skate over the surface in this period of time, because it is rather complex and rather difficult, and as other people have been saying, is all about culture, and is something that I think we have a huge job of work to do to try and address that. So I'm going to say something about person-centeredness, but then get into some of the things that we're involved in trying to make this happen, and some of the research that's happening internationally to create more person-centered cultures. I would want to say in terms of the 3 Ps that I would love if Bon Secours changed the top one, patients, which might seem quite a challenging thing to say to people, because actually you don't get person-centered cultures by just focusing on patients. You get person-centered cultures by focusing on all persons, and that is something we have to really get our heads around, and something I would also like to talk to Alan further about in that context. So I might put out some challenging things that hopefully we can take the challenge and do something with as well. If I am skating over the surface, and this is not a blatant promotion of some of our books, but actually it's just to say, if there's anything that I've said that actually does sound a bit intriguing, then it can be captured in probably the one that's most current is the nursing and healthcare one, because it's a multidisciplinary focus on person-centered practice and really contains in more depth most of the things that I'm saying this afternoon. It is really now kind of taken as almost a read that person-centeredness underpins most healthcare systems. And interestingly, I've just come back from my most recent chair, which is in China, where the Chinese government have just mandated human caring to be the fundamental principle underpinning all healthcare in China, and all clinicians have to adhere to human caring principles. Now, in the Chinese context, of course, it is a little bit hard to get your head around that, but actually it's quite an amazing thing. And the event I was at while I was there had all kinds of healthcare people talking about human caring and humanistic practice in the context of their practice as their primary focus, from surgeons to care workers. And it was really quite interesting to see that. But it's an indication of how significant now the whole person-centered agenda is. And the World Health Organization have it as their main focus in the development of healthcare systems globally. So it's not something that, as used to be the case, that it's something you do when you've done the proper work. It's now actually the core of the work that we do, and has to be at the heart of everything that we're doing in terms of developing systems, developing strategies, and developing our work. I could do this whole talk and another 5 hours with it on the difference between patient and person-centeredness, and I would really ask us to think through that we're not patient-focused, which might seem a horrible thing to say, and I really don't mean it in a horrible way, but we are person-focused, because we cannot have person-centered care for patients if we do not have person-centered principles for staff. It's a a given. And it's now been widely recognized that that's the case. And the literature is incredibly confusing about this, and some of the language that's used in terms of using patient and person-centered care, patient and person-centered cultures interchangeably doesn't help. But there is one fundamental difference, and actually the campaign in the UK, and particularly taken up in Scotland, I think gets at the heart of this. Patient-centered care asks, what's wrong with you? Patient-centered care asks what's the matter with you. Person-centered care asks what matters to you. And that opens up a whole different kind of conversation within the system. And it moves on and gets much more complex than that, because it is fundamentally about hopes, dreams, desires, and values of all people. Person-centeredness does focus on what we in our research have described as healthful relationships. I've been quite a critic, and I'm sorry about this, of the language of human factors, because it kind of adds a kind of a technical idea that these are factors that are somehow have to be made public in a sense within human beings. But what we know is that these are factors that are almost innate within all human beings, but that they often get buried within the systems that we engage in, and that they get dulled within the system. And what we want within our healthcare systems are what we refer to as healthful relationships, which are relationships that are health-giving to all of us, relationships that nurture us, that grow us, that challenge us, but not to the point that we burn out, that help us to flourish, that really make us the kind of the best human being that we can possibly be. And that's the kind of culture we want to work in. And as has already been said, most of the scandals that have happened, mainly in UK healthcare, have highlighted this issue, the issue of culture, and a particular factor, which is that of psychological safety, which is how psychologically safe do we feel to be able to challenge some of the practices that we see every day. But so if we are going to talk about person-centered care, I would suggest we talk about person-centered cultures, because you cannot have person-centered care without a person-centered culture, and that is really going to be the focus for a lot of my talk. For all persons, no matter whether we're a patient, a family member, us sitting in this room, these are 5 core characteristics that make us up as human beings and that are fundamental to humanity. And if we don't pay attention to those within our systems, then we don't have a system that values people, no matter what our mission statement says, or no matter what our values might express. If we don't actively work on these, we aren't doing something that is fundamentally respectful of persons. And there's lots of wonderful literature now that really gets at the heart of this. And this, again, has been said earlier. In my own practice, I see a lot of talk about providing individualized care, treating people in the way they want to be treated, and all that kind of language. And what I see then is everybody following formulas to treat everybody the same. What this quote kind of gets at is this whole idea is that the individuality of people is often very hidden, actually. It's often very hard to get at, and we don't get at it with some of our very technical kind of systems, competence-orientated assessments. We get at it at much more narrative-based work. And there's some interesting work coming out of Gothenburg in Sweden, actually, in this regard, where there is the Swedish Center for Person-Centered Care, where they are showing that a narrative-based assessment combined with a narrative-based care plan, combined with a system that works with that, actually hasn't just better patient outcome, it has also got better staff outcome, but probably of greater interest, it has got huge economic benefit, and they have shown significant reduction in bed days as a result of that kind of approach. And fundamentally, it's about holding the uniqueness of the person at the center of decision-making. One of my favorite books, and some of you may have read it, or you might have children who you're trying to read it to, and if you haven't, you should borrow a child and read the book, which is The Little Prince, which is really a philosophy of life, really, and about how to live a good life. And it's the book that I use most with our new student nurses, to get them to start to understand their own values and how they need to hang on to them. And it's the last line of this quote that is really important. For all people, what we see in front of us is a shell. What I'm seeing in front of me are a lot of shells. What is the really important thing are the deeply unexpressed values that you hold, that A is keeping you in this room, B might be keeping you interested, and C might be stimulating you to learn something. They are deeply held values that I have no idea about at this point in time, but which are driving you to be in the kind of space that you are right now. But they're invisible, and we have to find ways to get at them. We have spent 16 years now working with this person-centered practice framework, which is now working all over the world in various systems. But the only reason I haven't got time to talk about it is to kind of highlight that if we are going to talk about person-centeredness and patient-centeredness and all of those things, then we can't ignore the whole system within which we work. Within our work, which is largely action research and evaluation-orientated, we won't do that work unless we get chief executive sign-up, unless they are actually committed to looking at their HR policies, to looking at their strategies, to looking at all of those workforce elements that to see if they are person-orientated or are they system-orientated, and the person has to fit in. Because the kind of thing about this framework is that the outcomes are in the middle, and you have to kind of work your way through these layers to be able to get at those outcomes. And those outcomes are for all persons, for staff and for service users. So it is really important that we kind of don't just see this as something that busy clinicians do on a day-to-day basis, but that actually it is a whole system responsibility to have a person-centered culture. Back in 2013, we did a review of, at that point, our 12 years of research we had been doing in this area. And we did an analysis of it. And we mainly were analysing the narratives, because we use a lot of narrative and story work with patients and staff to get at these kind of invisible components of their work. And what we concluded was that most patients in particular experience in most days what we called person-centered moments. And they have moments within their 24-hour care period where they do genuinely feel loved, cared for, respected, that their humanity is top of the list and priority of everybody who comes near them. And then they have long periods of time where that's not the case, where people come in and out of their lives, do things to them, do things for them, give them partial explanation, give them bits of information, and go again. And it's a bit like a roller coaster in that respect. We also found staff had the same kind of experience, that sometimes they feel like they genuinely are part of a team, that they're not just a number, that they feel that they really are wanted, and then they have lots of periods where they just don't feel that. But of course, in those periods where they don't feel that, they are being expected to carry on being person-centered with patients who they are connecting with. And the irony of that is too obvious, really, for us to not pay attention to. We identified an array of factors in workplace settings where these things need to change, where we have to do significant work to change some of these things that are preventing person-centered care being experienced by everyone. Some of these challenges I'm not going to have huge time to talk about, but there are lots of them, and these are all evidence-based. And actually, this issue about physician-centered models is still a very dominant issue in many healthcare systems. And I love the idea around the way professionalism is changing, and I totally accept that. But we still have health systems that are often very physician-centric, and that is, again, one of the big challenges. There are also challenges for the rest of the staff, and again, this came from our research back in 2013, where we identified that actually nurses in particular were being given constant contradictory advice, really, as to what mattered, what was priority. And in all the time, it seems to be that, yes, providing patient-centered care is priority, but you can only do that if you do, in one of our hospitals, this is reality in Scotland, if you do the 100 audits that you have to do every month to show that everything is safe. So how do you prioritize those things if you're getting those day-to-day contradictions and keep the person at the center within that? Our most recent study was to look at patient narratives and to look at why it is that they often don't feel that they are treated as a person. And the key idea to come out of there was that they are constantly vulnerable, that they exist in our system in a state of vulnerability. And vulnerability is actually a really important concept for all of us because it releases the real person, because we let down some of our ego-based characteristics. But actually for patients, vulnerability and living in a constant state of vulnerability puts them in a very, very compromised situation. And so our role is to try and, how do we respond to that? And this has already been said today, but one of the reasons why that vulnerability happens is to do with the way that nurses provide inconsistent care. That if we can get greater consistency, then we can reduce some of the vulnerability. So how do we try and address some of those issues? We have done some work to try and get this into bite-sized chunks that people can try and work with and not complex theoretical models. And I just want to present these 8 principles to you and some examples of both work that we're engaged in and that others are engaged in to try and make these changes happen. The first one is what we've called bounding and framing practice, which fundamentally is what do you prioritize? What becomes greatest priority on a day-to-day basis? And for most clinicians, that is probably the thing that comes as the biggest challenge to providing consistent person-centered care, is the lack of prioritizing around what's most important. And I still work in places where the person-centeredness happens after the array of tasks are complete. And that is something we have to address because that is getting in the way of it. My colleague Tanya McCants has done a lot of work on person-centered KPIs. So not just kind of performance KPIs, but KPIs that are put into systems that genuinely focus on the person. And these are now being tested in 6 countries and are showing really significant results in changing both the language and the day-to-day reality of care for people in the system. How do we have all of these things coexist? Because we can't work in a system that is truly just focused on being nice. That's not what we're about. But in one of the health boards that I'm working with in Scotland, they are focusing their whole strategy on having more kindness in the system. And it's a wonderful idea, actually. How do we just get people to be kinder to each other? And within that, then how do we create the benefits of people being kinder to each other? So, for example, in the unit that I work in, within this health board, we have huddles for everything. There's about 6 huddles a day to do with patient safety. And I've challenged them to have a caring huddle, which kind of blew their head for a minute. It doesn't mean we all stand around and give each other a big hug, although that has happened. But it is where we actually check in with each other in terms of how are we feeling about the way the day and the way the care is connecting, and how can we actually help each other in a better way. For me, that's fundamentally about how we flourish as people. And again, human flourishing is an incredibly important part of all of this. Because if we're not flourishing, we're just existing. We're just doing the thing, not too concerned about it, not stretching ourselves. We have to really be flourishing and have staff who are flourishing. We have to also, in this third principle, really capture the creative energy of staff, because there's been a lot of talk of innovation today, but actually what we get dominated by is compliance. Compliance and innovation actually work against each other, and there's really good psychology theory to demonstrate this. And we've just produced a paper showing how organizations who are committed to person-centered culture are also often organizations who are absolutely obsessed with compliance. And actually, if you are obsessed with compliance, then you cannot have flourishing people, because what you have are people who are all the time worried about not complying. And if you're worried about not complying, then your energy goes into making sure you do comply and not taking risk, because innovation requires you to take risk. And how do we create person-centered leadership? And I know the next talk is about leadership. And we've had 2 PhD students now complete their work looking at person-centered leadership in different contexts. This one is here from Ireland, from Breege Lynch, who some of you might know from long-term care world. And both of these people, one in the Netherlands and one here in Ireland, have developed models of person-centered leadership. But at the heart of it is this idea of authenticity, which is authentic leaders who are real, which is really fundamental to actually staff engaging and creating these contexts. We also need to stop every now and then. We need to create spaces for reflection. Certainly in many healthcare systems and many organizations, the whole idea around mindfulness, creating spaces for wellness, has become normalized practice. And there's a good reason for that, because there's fantastic evidence to demonstrate the health benefit in relation to things like mindfulness, meditation, etc. But fundamentally, we have to shift from a culture of the busyness of practice, as Peter Jarvis has described it, to the business of practice. How do we create the business rather than focus on the busyness? And actually, reflective decision-making is fundamental to us doing that. And how do we build that into our system? It doesn't have to take a long time. It can be done through quite creative methods, and it can be done as part of routine practice if we are committed to it. That builds on individual capabilities, because capability is really significant to all staff. Every member of staff in every one of your units has capabilities that have been untouched, that are sitting dormant within their day-to-day work because they're focused on particular tasks. And your responsibility and our responsibility is to actually release those, to enable those people to be the best person that they can actually be. One of the big lessons that everybody has when they start doing person-centered work is that it's not about massive organizational change. And I could have presented a statewide project we've completed in Norway for mental health services with older people that really shows that. It was started off as a reorganization project in the municipality, but actually what it turned out to be was how do we connect older people together through safe spaces in their community. And the insignificant is what patients in their stories tell us really matter to them. And the story from my own practice is to do with a nurse practitioner that I work with in the emergency unit, who I work with in the frailty team in this unit. And he is a nurse practitioner who assesses and does all these things to get people out of the unit as quickly as possible and move them back to their nursing home or wherever. And we have this woman who came in her late 80s, quite unwell, had been assessed in the night by the medical consultant who made her nil by mouth. And at this point, she was now nil by mouth for nearly 24 hours. There was no need for her to be nil by mouth all that time. But nobody had seen her until the nurse practitioner came along. And he said to her, "What matters to you?" And she said, in lots of swear words added in her Fife accent, was, "I want a glass of cold milk." And his mission for the following 20 minutes was to get that medical consultant there, get the other people there, and to have that nil by mouth sign removed, which we did. And 20 minutes later, she was having her glass of cold milk, and she said to him, "I love you, son." And he said, "I think I love you too." And it was this kind of moment where you could see proper, real caring, but actually totally transformed that woman's care. This kind of work isn't a project. It's not a 6-month project that you do in a service improvement grant. It's actually a lifelong commitment to changing the cultures of the settings in which we work. Don Berwick, the founder of the Institute of Health Improvement, who was mentioned earlier, actually came out in a recent talk that he did in London to actually really challenge this idea of being obsessed by data. And what he had said, which is still online if you want to Google it, is that this obsession with compliance and data just creates fear, and it doesn't create innovation and creativity. And what we have to do is create learning cultures within our settings where people are constantly learning, and through their learning, they change practice. I would want to end and say that fundamentally, this is about loving kindness. Love is a word that we have kind of written out of our lexicon in healthcare, but actually we need to put it right back in, because person-centeredness is fundamentally about loving what we do, but also loving the work that we're engaged in and the people who are engaged in that. My colleague in Norway, Professor Kari Martensen, has this great idea around that, which is that every time we touch somebody and we connect with somebody in a meaningful way, in a proper person-connected way, that we actually take something away from them. Something of them connects with us that keeps within our memories and that influences the way that we care from there on in. And for me, that is just about being present in the moment. I've had various experiences over the past 18 months as a service user with my partner, going to GPs, going to consultants, going to various services in the Edinburgh area. And, it would have been such a different experience if those doctors were present. They were physically present, but they certainly weren't always emotionally present for each of those consultations. And that would have changed those whole experiences, absolutely, made them very different. So, to end, we have to make more person-centeredness more real. It can't just be something that's in policy documents and strategy documents as focused on patients. It has to focus on how we change the cultures and what it is that we within organizations are paying attention to. We've got to have strategic plans that make this explicit. It has got to be explicit or it will not happen. And as somebody said earlier, if it's not assessed, it won't happen. Well, if it's not explicit, it won't happen either. And lastly, I would want to challenge all of us. There is a real tendency for managers and leaders to say they have got to be more person-centered. I would say no. The challenge is for all of us to be more person-centered and to create that change in ourselves first and to think about the next conversation that you're going to have with somebody and how do you actually have that conversation, because that's where the real revolution actually happens. Thank you.